My name is Emily Crawford, and I am a fourth-year student currently completing my radiology elective at Stroger Cook County Hospital. Today, I am going to talk about deciphering lines and tubes in ICU chest x-rays. I am applying internal medicine, so I am hoping that this will serve as a guide for basic interpretation of chest x-rays while rotating through the ICU. So starting off with just some general principles, the first thing that we think about when approaching any imaging is what prior images are available. Did the patient have an x-ray the day before that we can, compare this current image to? Perhaps they had a CT scan that might be insightful as to what we're looking at today. So taking a quick stock of what images have already been obtained recently. The second thing to consider is what the indication is for the current image. It might just be to confirm a line placement, or it might be a daily x-ray that we're using to assess the patient's condition. Then the third thing is to think about what interval changes we know have occurred based on the patient's chart, and ensuring that the current images reflect those interval changes. So for example, if the patient has been extubated since the previous chest x-ray, then just confirming, yes, indeed, the ET tube has been removed. So how I organized what I've learned about lines and tubes for my elective is into this ABCDE categorization. I enjoyed that for learning how to interpret chest x-rays in general earlier on in medical school, and so I figured I would organize this into a similar classification system. So here you'll see the ABCDE stands for airway, breathing, circulation, drains, and enteric tubes, and we'll take a deeper dive into each of those throughout my presentation today. So starting off here with airway, we want to be considering, is the patient intubated or not? And if they are intubated, we want to be taking stock of where the tip of the ET tube is. So this image here on the left came from an article published in Nature, and it labels some really important anatomic landmarks that we want to take into account when assessing ET tube placement. So the biggest of those being the carina. The carina is where the trachea bifurcates, and when we are assessing ET tube placement, we want to ensure that the tip is 3 to 7 centimeters above this carina. So if it's not in that area, we would need to ensure that it either be pulled back or inserted further in the trachea. This image on the right came from a Radiopedia article, and it shows an ET tube that's coming down here through the trachea, but it's gone too far, and it's in the right mainstem bronchus. So the right lung is being adequately ventilated, and the left lung is completely whited out because it's not receiving any ventilation at all. Next, we'll talk about breathing. So with breathing, we want to look at the lungs and some sort of devices or tubes that we might be looking for are chest tubes. And so we can see on the left, this is an image from Radiology Masterclass. We see a chest tube here. It's been nicely highlighted for us in this image to the right, but this is what a chest tube would look like projecting over the lung space. And as you can see in this case, there was a pneumothorax, pretty large pneumothorax that this chest tube was likely inserted for. But it can also, chest tubes be used to drain like hemothoraxes as well as large effusions, or placed in post-surgically as well. In this image here on the right, we see some bilateral endobronchial stents. So this image came from Radiopedia, and we can see here in the right mainstem bronchus, there is a radio-opaque stent-like structure, as well as here in the left mainstem bronchus. And so those were placed bilaterally. Moving on, we'll talk about circulation. There's a few different things to look for as far as lines and tubes when talking about circulation. So we'll start with central venous catheters. So on the left here, we have just an image from an article I found online, which I thought demonstrated the placement of a central venous line very well. So as you can see, the lines here was placed in the jugular vein and is coming down. And if we follow the tip is located in the distal superior vena cava, just proximal to the right atrium. So this is an ideal placement of the tip of a central line, and typically it would be at the same level as the carina. So it's another good reference point in terms of evaluating central line placement. On the right, we have an image here from Radiopedia demonstrating a Swan-Ganz catheter. So as we can see, it's coming down the superior vena cava, coursing through the right side of the heart, and is now in the pulmonary artery system. However, as you can see, the tip is sort of off to the right here, and it's actually too distal within the pulmonary artery space. The ideal placement for the tip of a Swan-Ganz catheter is going to be more in the proximal portion of one of the main pulmonary arteries, typically in the right main pulmonary artery. So ideally, this tip would be more centrally located here. Another thing we want to consider with circulation as far as lines and tubes go are other catheters. So these two images are both from Radiopedia cases, and this one on the left is showing us a portacath identified here, and we can see that the tip is projecting, looks about right over the right atrial space, so that's appropriately placed here. And then on the right, this image shows a dual lumen permacath. These are typically used for hemodialysis, and so we see that it's projecting down here, and that its tip again is also just about in the right atrial space. In this image, you can also see some sternotomy wires here, evidence of either a cabbage procedure or another cardiac procedure. The last thing to take into account as far as circulation goes for lines and tubes is cardiac devices. So like the rest of this presentation, this is not an exhaustive representation of all the cardiac devices, but two fairly common ones are going to be a pacemaker and an ICD. So on the left, this image is from Radiopedia and is showing us a pacemaker here with its leads coming down, one of the leads terminating in the right atrium and the other lead terminating here over in the right ventricle. And on the right, we have another device here with its leads coming down. We have one going in the right atrium and one coursing across here to the ventricle. And as you can see, this lead is much thicker than this lead over here, and that tips us off that this device is an ICD. So if you were trying to identify a device purely by just looking at the chest x-ray and not going into the chart or asking the patient about their history, this thickness here of the ventricular lead can help point in the right direction. Moving on here, we'll talk about some drains. So lots of different types of drains can be seen on chest x-rays. I'm going to talk about the ones that are visualized in the chest cavity. However, on a chest x-ray, you may also get the upper abdomen in your view, and there can be drains there as well, but I won't talk about those at this time. So this first image here is demonstrating to us a left pigtail catheter. So you can see it's sort of entering the chest wall right about here and is coursing just about here, and sort of you can see the pigtail itself here on the left side. So this was draining a pleural effusion there. This middle image here is showing us a pericardial drain. So as you can see, here's the tubing. It's sort of turning over on itself here, and the tip is just about there. So this tubing is actually in the pericardial space, so in that space just surrounding the heart, and these types of drains are placed to drain pericardial effusions. And then on the top right here, we have a mediastinal drain, so it's actually going to be this structure here coming down here, and then connecting to the external portion of the drain. So this is usually placed after some sort of like cabbage type of procedure to drain the mediastinal space. But just looking at this x-ray as well, we can see there's a few other of the lines and tubes that we've already talked about. And you can see a central line coming down here. You can see a chest tube here, some more sternotomy wires, and you can actually see an ET tube here as well. So the last portion here is enteric tubes. These are another very common thing to see on ICU chest x-rays, and it's important that we have proper location of our enteric tubes. So these can be nasogastric tubes or Dobhoff tubes, but each time they're placed, we want to ensure that they are located in the right spot. So as you can see, this image here on the left, these are both from the same Radiopedia article. You have this sort of radiopaque line coming down here. This is an enteric tube, and you can see its tip terminates right here in the gastric antrum region. So that would be an appropriately placed enteric tube. This image on the right is showing us a malpositioned enteric tube. So you can see that this, similar tube is coming down and it's making a turn here, which is unusual, and then it's going here. And if you're seeing this, you might be thinking to yourself, this is actually the bronchial tree, and that is what's going on. So the enteric tube was placed down into the trachea as opposed to through the esophagus. So the tip of it is projecting into the left mainstem bronchus. And this would be, of course, very dangerous to actually use this tube as a feeding tube because it would cause some significant aspiration. So seeing this on a chest x-ray immediately would need to intervene and ensure that the tube be repositioned. So I'll wrap up the presentation today just by summarizing what we talked about. We walked through the ABCDEs of lines and tubes on chest x-rays. So this was a systematic approach to ensuring that we assess for all of the different leads and lines that are present on chest x-rays. So starting with airway, we talked about ET tubes and how the tip should be 3 to 7 centimeters above the carina. Moving on to breathing, we talked about assessing for chest tube placement as well as possible endobronchial stents. With circulation, we talked about central lines and that their tip should be about in the distal superior vena cava, close to the junction of the right atrium. We talked about Swan-Ganz catheters and how the tip of those devices should be in the right main pulmonary artery, the proximal portion. We talked about identifying cardiac devices and checking that their leads are properly placed. With drains, we looked at a drain in the pleural space, in the pericardial space, and in the mediastinal space. And with enteric tubes, we talked about identifying the tip of those tubes being in the digestive tract for one, and for two, that they were distal enough within the stomach or the duodenum. And as one final word, there of course are many different ways to read chest x-rays, and there are many different ways to keep track of different lines and tubes. This is just one approach, and hopefully you found that helpful. Lastly, here are my resources for the images and articles referenced throughout my presentation. And just want to say an additional thank you to the residents and attendings who contributed to the teaching on this matter throughout my rotation.